Very vast topic covered in a short term of 20 minutes. Difficult to manage, but very well done, sir. Great emphasis was done regarding cardioversion. It's a must that everybody in the hospital, starting from the consultant to the staff nurse and the trainees, they should know the art of cardioversion. There is no excuse for that. The one arrhythmia which respond very well to cardioversion is flutter when compared to fib. Many a time, whether it is flutter or fibrillation, we will miss. It won't respond. Flutter many a time won't respond to the medical therapy, and it will respond very well to the cardioversion, whereas the fibrillation won't respond very well to cardioversion.
Absolutely right. There is hardly any medical therapy for flutter. Now, in fact, many of the flutters actually just spontaneously terminate if you give it 24 hours. So flutters, like you rightly said, you control the rate and then you cardiovert.
And many a time we'll have a doubt whether it is a sinus tachycardia or atrial tachycardia if the rate is very high. And if we keep on, if we try to cardiovert it, if it respond, probably it may be atrial tachycardia, provided the atrial tachycardia is of re-entry type. There are three types of atrial tachycardia: automaticity, triggered activity, and re-entry. All the arrhythmias which responds to the cardioversion is preferentially uh, re-entry type. So if it is not getting cardioverted, probably you are shocking a patient with a sinus tachycardia. These things can happen in hospital setups. And regarding cardioversion for atrial fibrillation, if you have time to anticoagulate the patient, give anticoagulation, at least give heparin, and don't forget to continue anticoagulation for at least 4 weeks after the cardioversion, because the risk of embolism still persists till 4 weeks after the cardioversion.
Absolutely.
Right.
Yes.
That was an excellent talk, sir. Sir, in an unstable VT or a VF, when it is resistant to DC shocks, do you resort to this double sequential cardioversion that has recently been described?
Yes, that is, yeah, thank you for bringing that up. That is something that you should be aware of. If a patient has not responded to cardioversion, I'll first go to atrial fibrillation and ventricular fibrillation. If a patient doesn't respond to standard cardioversion for atrial fibrillation, please put the patches anteroposteriorly. In fact, for all atrial fibrillation, it is better to put paddles anteroposteriorly. The reason why we put paddle from here to here is because we are trying to get as much of the ventricle between the two paddles. But if you want to get as much of the left atrium between the two paddles, remember that the left atrium is a midline posterior structure. There is equal amount of left atrium on the right side and left side. So if you want to cardiovert the left atrium, put your patches anteroposteriorly, the front patch right on the sternum. And the second thing, like Vikram said, is don't forget the reasons why cardioversion fail. One reason why cardioversion fails is you've not got enough energy into the heart. And one simple way of getting enough energy into the heart is use two sets of patches. Use anteroposterior paddles as well as paddles from here to here. Two people operate the two paddles, and you count down to 1, 2, 3. At the count of 3, you shock simultaneously. So if you do that, you get more energy into the heart. The other very important things to take care of is another reason why energy doesn't get into the heart is air. If your cardioversion doesn't fail, it's an emergency situation. Intubate the patient, cardiovert in exhalation. Tell the patient, tell the anesthetist to hold the breath in expiration. So there is no air between the heart and the outside part of the thorax. Often works. You just have to repeat the same cardioversion with an anesthetized patient with the breath held in expiration. So these simple things people must know of why cardioversion fails.
And a quick comment on your phosphenitoin, because phosphenitoin, the advantage of phosphenitoin is the over phenytoin is the rapidity of infusion.
Yes.
We usually give the 600 or 800 or 1 gram within 10 minutes span.
Yes.
But what is the reason for you to give over 1 hour?
It's in a stable, it depends on the extent of stability of the patient. If like somebody's had a VT now and has the VT after 3 or 4 hours, I give it over 1 hour. But if the patient is going to have recurrent VT, I'll definitely give it over 10 minutes.
Can you quickly say how a patient who is having an ICD comes with a shock in a peripheral or non-EP setup, what should a physician do? Patient who is on ICD having a recurrent shock appropriate or inappropriate, what is the next step in the management?
So the first thing, if a patient comes with an ICD and a shock, is ask the patient what he felt before the shock. If the patient says that before the shock I was feeling bad, I was feeling giddy, I was feeling dizzy, this is very likely this is an appropriate shock. There is a problem. Please refer the patient to a place which can handle an ICD. The patient says that no, before the shock I was perfectly fine. I was talking and I was walking down the stairs. Then I got a shock. Then I got 2 more shocks. Then I got 3 more shocks. And he says if you get 6 shocks like that, then very likely that this is an inappropriate shock. In that situation, what you do is admit the patient to the ICU, keep the patient on a monitor, and don't do anything. Just keep the patient under monitoring. And if the patient gets an inappropriate shock, it's getting under monitoring. You just put a magnet on the ICD, it will disable the shock. But most important thing, before you can interrogate the ICD, is ask the patient what did he feel before the shock. That will give a good clue whether it was appropriate or inappropriate.